So the photophobic Bell's phenomenon eye. This right eye qualifies. We can see the lower third of the cornea. We know there's a superior part, but we can't see it yet. So let's see if encouragement works. Try to open both eyes and look down towards your shoes. Transient benefit to that. Okay, how about a little manual help here? Nope. So now we're going to go to chemical help, which means sedation. Last would be a peribulbar block. So again, I'm now encouraging the globe to go down. And what we'll do is one other thing here in a second. We will go to a Trendelenburg position, which gives us better visibility regardless of the patient's globe position. So I'm going to let go of the eye and we'll Trendelenburg the patient. And you can see now we're actually doing better with some IV sedation. So let's go table up. And now tilt down. A little more. Good. Okay. So after the, and I think it's more the intravenous sedation that's helped us here. Now these patients tend to be hyperesthetic, so this cotton tip applicator is soaked in anesthetic. That makes it less likely for the patient to feel this. And the sharp edge is up just in case we get a repeat Bell's at any point in time. We don't get a big incision. And now for our 2.4 millimeter. And we'll be testing the anesthesia now. There'll be a little sting. Patient may not hear that very well from the sedation, but appears not to feel it. Okay, so there's talk of doing cataract surgery in office, whatever that means. And my experience has taught me that call it in office if you want, but you've got to have all of the abilities to do it as if it's in an operating room, which means very significant sedation with the cornea. You never know when you're going to need it. Eye surgery is far too precise to be doing on patients that are anything but immobile. The capsular excess is a perfect example of the need to have precision. So there's our hydrodissection. And now viscodissection. And when I do the phaco, I mean, anesthetic is terrific, but it can wear off. What if the patient moved? So my technician is going to have his or her hand on this patient's forehead just in case during the really sensitive parts of the procedure, such as the rhexis and now the phaco. Okay? And you can't see the hand, but it's on that forehead. So this patient can't move very far. Now, I don't like that infusion capacity. Let me just do that. Now it's better. And when I begin infusion, the patient might feel that. This is a highly myopic eye, so we're stretching stuff. I'm just testing to see if it's choppable. Let's lower IOP to 50. Again, we don't need to stimulate this patient. So we're going to do this with a low IOP. That it won't affect chamber depth much, which those of you watching in 3D can see is rather extreme. But it will affect how much we stretch the choroidal nerves and how much the patient feels. Now these eyes that are super deep are a little tricky to sculpt deep because you're at that angle and you don't get to see as much. But I've got a red reflex there now, and that'll be good enough for me to divide this lens. Okay, so we're going to go to quadrant removal and IOP of 50. So here's our last segment. And it's very nice to be able to use high vacuum and still have a relatively low IOP for phaco. Because the high vacuum helps me to hold on to lens fragments and aspirate a lot of them without ultrasound. So the majority of the lens was removed without ultrasound. Now we're ready for INA. And during INA, we'll also use a low IOP of 50. Testing infusion, which is poor, till I rotate the sleeve, and now it's good. IOP is 50, and the patient's nice and stable. We're going to keep a hand on his forehead. He's a little bit lighter and making some human noises now. Super deep chamber. I'm going to catch his cortex centrally and bring it to the periphery and then remove it. Okay, we'll move some epithelium from under the anterior capsule. Now we're ready to put in our IOL, and in this case, we're putting in a multifocal. I'm going to just shallow the chamber a little. Why did I do that? So that I could just polish this posterior capsule. I let it come up. It had some little fibers on it. And as I inject OV and it gets deeper, wet the cornea, please, it kind of gets out of my focal range there, and it's a little harder to, and it's still not at maximum depth. Alright, so that's about as well as I can polish it. And now I'm just going to fill it so it gets really deep. And now we'll inject our IOL. You can see the capsular rhexis. The capsule is still there, trapped in viscoat. We'll get rid of that in a minute. So there's our multifocal IOL injected into the capsular sac. Capsular rhexis forceps. And there's the release of our haptic spontaneous there. So now I'm going to nudge the IOL to the side. Everybody is being utilized here. Our anesthesiologist is now going to give the patient something probably to wake him up. The technician still is holding his head. And we've removed OVD. Let's see if that capsule flows out of the eye. If not, we'll aspirate it. I think we'll have to aspirate it. Let's have the INA tip. So I just caught that anterior capsule with the INA and extracted it. And we'll irrigate the angle. And there's a little bit of mucoid stuff there. Let's get rid of that. And stromal hydration. And we're done.